Hit the subscribe button or visit us at auau.auanet.org.
Okay, good evening, everybody. Welcome to our webinar entitled AUA National Medical Student Curriculum Committee takes you on a tour of urology, a behind-the-scenes look at an amazing specialty and how to get there. So we have some participants this evening, faculty who are going to be talking with you. We want to welcome you from all across the country. My name is Dr. Seth Cohen. So I'm an assistant clinical professor in the Division of Urology and Urologic Oncology at City of Hope. My specialty is female pelvic medicine and reconstructive surgery. But more importantly, let's get to our fabulous panelists this evening. So our first panelist is Dr. Gina Badalato. So Dr. Badalato is an assistant clinical professor of urology at Columbia University. She's also the director of urology for medical student courses. And she's got a very distinguished training career, including Columbia residency, a fellowship at Columbia in voiding dysfunction and endourology. She's won numerous awards, including being the recipient of a Society of Women in Urology Travel Award for her research, and also being a superb teacher as well through the American College of Surgeons. Our second panelist is Dr. Jessica Kreshover. Is equally as distinguished. She is an assistant professor of urology at Hofstra North Shore LIJ Medical School and a faculty member of the Arthur Smith Institute for Urology. She also is a director of medical student urological education. She did her training through initially medical school at University of Virginia, residency at Boston University, and then a fellowship with some extremely well-known people in our field, Dr. Cavusi and Dr. Richstone. And she's done multiple live surgeries all throughout the world. And she has a very interesting past of being an engineer, for which she won numerous awards with her talents as an undergraduate. So what we like to do this evening is really give you an exposure to what urology is as a field, and also to how to apply and get through that process into a training position. That's a large task to accomplish in a relatively small amount of time. We do want to give you the opportunity to ask questions, and so if you notice on your web page, there is the ability to get those questions to us. I would encourage you to do that throughout the broadcast, and we will have time at the end to answer some of those questions. So I want to get started and move right into it. So let's start with Dr. Badalato. Dr. Badalato, can you give us a sense of what makes urology unique compared to other subspecialties like ENT and ophthalmology?
Thank you, Seth. Thank you for the introduction, and welcome everyone who's tuning in this evening. I think it's an important question because often students are trying to choose a surgical subspecialty among their required elective time, and they're looking at other fields like ENT and ophthalmology, or even during the course of their career planning. I think the differences lie in the greater anatomic diversity within urology. We're covering problems from the kidneys, the upper tract, the bladder, and the lower urinary tract in men and women. There's a greater diversity in terms of lifestyle and surgical approaches. We can have mostly office-based procedures, endoscopic procedures, and open major procedures. And, you know, the common thread in urology is that it's a nice mix of medicine and surgery, and I feel that the longitudinal relationships that clinicians and their patients form are greatest within urology.
So that's an excellent description. Thank you. And Dr. Kreshover, what would you add to that?
Thank you also, Seth. And I totally agree with Dr. Badalato. The one thing I would say is I think that ear, nose, throat is probably the closest in terms of surgical subspecialties to urology in terms of its breadth and the patient mix from both inpatient and outpatient type. The other part, though, is that urology is on the lower end in terms of emergencies. You know, ENT is responsible for airways, and there's going to be more surgical emergencies, and therefore potential for higher acuity than something like urology, which has relatively few emergent things.
Yeah, and you know, it's my little 2 cents is, if you look at the leadership of surgery departments across the country, inevitably, I think urologists tend to rise at the top because of surgeons. Not only are they technically talented, but they often are the best communicators. I say that biased, obviously, but urologists communicate very well. And if you know, it's probably because we talk about very personal things with patients. Very few patients will open up to you if you can't communicate. Okay, so Dr. Kreshover, give us some examples of patient populations that urologists are commonly working with.
So one of the good things I think about urology we've said is basically the diversity in every respect, and certainly in terms of patient populations, I think that an awesome part is the diversity of both ages, sexes. A common misconception is that urology is kind of is mostly a male-focused subspecialty, and while certainly there's an abundance of male urologic diseases, kidney stones, kidney cancer, bladder cancer, voiding dysfunction, none of those things are common to only males. It's both females and males. And I know for myself, I mean, I'll in a given day see patients anywhere. I saw a 17-year-old today and a 91-year-old. So it's a big diversity.
Okay, great. And what about you, Dr. Badalato?
Yes, I completely agree with what Dr. Kreshover is saying. You know, a common misconception among students is that, as she was mentioning, that we deal exclusively with the male population. And while that is a major part of what we do, urologists treat 3 of the top 10 cancers in the U.S. population. 2 kidney and bladder affect men and women. So within urologic oncology, there's a diversity amongst genders. Within voiding dysfunction, the field of female urology, there's a lot of overlap with gynecology in that you're managing, voiding dysfunction in women, but also treating pelvic floor prolapse at times. And then pediatric urology is a field unto itself that focuses exclusively on the care of children. And the beauty of the field is that during residency training, a given trainee will have exposure to all of these patient populations and age groups and be able to experience all these elements of urology within these different populations.
These are excellent answers. I don't have much to add because you both covered it so well. Okay, let's keep moving. So let's go back to Dr. Badalato. Dr. Badalato, what has surprised you about your current practice and lifestyle? And be open, and honest. It's something you didn't expect when you began this journey of urology, and it could be good or bad.
Yeah, becoming a doctor, I think, at some point we all have tunnel vision where we're looking towards getting through our pre-medical training in college and getting into a good medical school. And once we're in medical school, we're really focused towards residency, a residency in urology. And once you become a resident, your work schedule is very busy and you're looking towards just getting through each year and accomplishing the milestones that you want to accomplish. And at some point, kind of life trickles in and priorities shift, and that kind of occurred for me with having 2 children after finishing residency. And what surprised me the most was that with urology, I could kind of mold my practice and my focus and my time and schedule based on, the needs that I had at that time, or that I do have now at home with my 2 kids that are both under the age of 3. So the versatility of the field was really surprising. And it's something that I definitely am very thankful to have.
No, I think you're wonderful. We'll get to more of this later on in the discussion, but you're a wonderful example of how, you can really have it all in urology. There is an opportunity for that. Okay, what about you, Dr. Kreshover? How would you answer this question?
So mine is also relatively personal in that I was not one of those people that grew up saying I was going to be a doctor. I mean, I didn't at all. I did engineering at first. The only thing I've ever wanted is to wake up in the morning and go and not want to shoot myself when I say I'm going to go to work today. I just wanted to have a job I enjoyed and that came with a lot of personal satisfaction. In medical school, I did not think I wanted to do urology. In fact, I didn't think I want to do anything surgical just because of training and timing, etc. And I kind of fell upon it very late. And even at the time of deciding to go into it, I don't think I knew for certain that it was exactly what I wanted to do. And in retrospect, I can't really imagine doing anything else at this point. I think it's given me a sense of satisfaction kind of in every respect, that I've gotten to do a little bit of everything that I want. I love the surgical aspect, and as an engineer, like physically seeing something and being able to fix it. Dealing with patients every day. I bragged last week that there was one day where I had 4 patients give me a hug and a kiss. And I think that there's just a lot to be said about just how important the job that I wasn't really expecting to has become to me.
Excellent, excellent. Well, thank you very much. Excellent answers. Let's keep moving. Next slide, please. Okay, so let's get down to some of these questions that come up regarding the application process for urology. Urology is very competitive to get into. Let's start again with Dr. Kreshover. So Jessica, how does an applicant navigate the concern about cutoffs for USMLE scores and honors grades? What can you tell us about that?
So when I counsel people about this, you know, the cutoffs in a way do exist. You know, most places are using some sort of baseline score. Urology is a very competitive field, and you know, probably if you compare amongst most people are using something around 230 and above to kind of sift through the applications. That being said, it is not at all the end-all be-all. You have to have your application be seen in order for someone to consider you. And so a lot of places, because they use the cutoffs, your application may never even come across their table. And so what I tell students that may have scores that are a little bit lower, while yes, it may put you at a disadvantage, there are other ways that you can buff up your application, and also to personally reach out to programs to say, hey, I know that this is a weakness in my application, but if you look at this, this, and this, I think I've shown that I have these other attributes that are going to make me a successful resident and future urologist.
Very nice, thank you. And so Dr. Badalato, what would you say to a student that walks into your office, is like, I really want to be a urologist, but I'm concerned, I don't know if my score is there, I don't know if I can do it?
Yeah, so there tends to be, in terms of cutoffs, more for the USMLE score than for honors grades when programs are sifting through applications and deciding who they're going to be offering an interview to. So if somebody's USMLE score is kind of below the national average, or again, as Dr. Kreshover mentioned, 230 has been kind of the rough cutoff amongst many institutions to grant an interview. I would recommend to that applicant that they do things to enhance their application. A very common venue to do that is to engage in some form of clinical research, and that's going to establish a relationship with a mentor within the department, and also give you the opportunity potentially to present at national meetings or specialty specific meetings. But whatever you can do basically to almost self within the field of urology and get a mentor, somebody that's going to be making calls for you or writing a good letter of recommendation for you, are all things that can really help overcome the USMLE score.
Yeah, I totally agree with all this, and I would add 2 little bits of information. Number 1, advocacy. You need an advocate. Whoever you are, no matter what your score is, whether it's top-notch score or a less than top-notch score, you need an advocate. Someone needs to be in your corner. You have to identify someone who will make calls for you, give you advice, go to bat for you. Find that person. Find that person, because they will be key to your success. The second piece of information is, I've never known someone that wholeheartedly 100% wanted to do urology and couldn't find a way to do it if they really wanted to. Maybe it was a circuitous path, maybe it was a couple of years of research like Dr. Badalato was saying, maybe it was doing a couple of years of prelim, but I tell you what, if you want it bad enough and you keep trying, I 99% chance you're going to get there. Okay, let's keep moving.
I completely agree with that. Where there's a will, there is a way.
Yep. We all know these stories of people that have done this. Okay, next slide, please. Okay, so let's go back to Dr. Badalato. Dr. Badalato, so what's a common pitfall you've seen with applicants applying to urology?
Okay, one of the most important things that you need to have, in a successful application of urology is simply just to have the application in on time, complete and on time. So we all know that this is an early match. The application deadline is early September. So this may be tricky because some people are completing some visiting sub-internships at the end of September and maybe waiting for that last letter of recommendation to come in. You need at least 3 full complete letters of recommendation for your ERAS application to be viewed and available for program directors to view it across the country. Don't wait for that last letter of recommendation to come in to have a complete application. Do whatever you need to do, even if it involves getting an extra letter of recommendation from your home institution, to have all your requisite letters of recommendation in for your ERAS application to be complete. Because many programs offer rolling interviews, and you don't want an incomplete application to be one of the reasons that you're overlooked. And that would be one of the more common pitfalls that I see.
Sure, sure. Okay, Dr. Kreshover. So what does an applicant do that just makes you cringe? What's like, oh my gosh, I can't believe it.
So mine is an easy answer, probably not everyone's favorite or one they would expect, but generally after looking at the basic biographic information, the very first thing that I look at is the picture submitted. And so to me, it's always, again, they say you never get a second chance to make a first impression. You're sending an application. It's in essence a job interview. And if your first impression on a job interview is having, the disheveled hair and jeans and a ripped t-shirt on, it's just not exactly the persona that you want to be given off in the field of medicine. It's important to look your best, to portray your best, both in an office setting to patients, etc. So that is it is definitely my cringe-worthy thing, the photos sometimes people submit.
Sure, these are excellent answers. Let's keep moving. Next slide, please. Okay, so this is very important for planning for your application as well. So, Dr. Kreshover, when it comes to sub-internships, how important is your choice of geography?
So the two things I'll say on this is, number one, I think that a big part, people try in a way to pigeonhole themselves into saying I want to be in one specific part of the country or whatever, and whether that's right or wrong, again, urology is very competitive, and to me, if it's something that you really are invested in doing, I think that it's within your best interest to try and be as geographically diverse as possible. When it comes to choosing the sub-internship, I think an important part is choosing somewhere where, number one, it's a place where you want to go, potentially, for residency, because spending 4 weeks with people is going to give them a much better impression and more information about you than a half-day or one-day interview can. And so a lot of people get their residencies from places they do sub-internships. So you want to pick a place both geographically but also realistically that is in line with where you can see yourself for residency.
Very good. And Dr. Badalato, what would you add to that?
Yeah, I completely agree. We actually did a small study looking at, what are factors that predict whether someone is going to match in the urology match. And the number one predictor that showed, where someone was going to match and if they were going to match was basically they matched they matched at a place where they did their sub-internship, where they went on that 4-week job interview, where they were well known. I will say, in terms of geography, if you want to open up a geographic region for yourself, you should definitely do a sub-I within that, that AUA section within that territory. So if you were kind of born and raised in New York and spent your entire, life in the Northeast for college and medical school, and you're interested in training in the West Coast, you should definitely do a sub-I, within that geographic area, because sometimes when people are looking through applications and we're looking at a batch of all very, very qualified people with similar board scores and all coming from great schools with impressive resumes, then you turn towards other, looking at other variables like, is this person likely to come here? Should we offer them a spot for an interview? Or is this someone that's even serious about coming here for residency? And the way they deduce that is looking at your geographic preference, your geographic record.
Yeah, you both have underscored this so well, but this is a very important decision. I would not underestimate how important it is when you choose your sub-Is and where you go. Those are your best opportunities to make an impression. So be very calculated about where you're doing that. Don't choose places that perhaps are, I don't want to say beyond your reach, but be reasonable. Be honest about yourself, about the type of applicant you are and where you want to do your training and what you see yourself doing in the future. Okay, let's keep moving. Next slide, please. Okay, so let's go back to Dr. Badalato. So Gina, who do you think should write the letters of recommendation?
So letters of recommendation, you should definitely have a letter of recommendation from your home institution. That may be your chairperson or the program director writing a letter on your behalf, basically saying that you have their benediction and endorsement for a career in urology. Anyone that you've worked with in a research capacity, this can be an assistant professor or a full-on professor, but anyone that can write a strong letter of endorsement that you are committed to a project, and you made valuable conclusions from the project, that you have good character, that you're reliable, that's very valuable. And then definitely places where you've done your visiting sub-internships. And this is where having a mentor and a counselor is valuable, because they can help not only give you advice on where to do the sub-I, but who within that institution traditionally writes letters of recommendations for visiting sub-Is, because urology is a very small field, and to some degree, you only want urologists want to read letters from other urologists that they know and trust, and say, oh, this, so and so has been training residents and students for years, and this person thinks that this student did an outstanding job. They must really be outstanding. So the endorsement of other urologists and other well-known urologists in the field is really critical.
Very good. Very, very important information. Okay, Jessica, what would you add to this? Who should write the letters?
So I agree with Gina. The only thing I'll add is that while it is important, or it's valuable, I guess, to have people with, as we would say, a bigger name within the field, the most important with the letter, again, still being within the field of urology, is to have one that's solid. So if you haven't spent a lot of time with someone, but they're a bigger deal, so to speak, it's better to have a stronger letter from someone that can really speak to you, rather than a generic one, or one that isn't as glowing from someone that other people may deem, higher up on the totem pole.
Yep. No, those are perfect answers. Why don't let's keep moving. Next slide, please. Okay, so let's go back to Dr. Kreshover. So what is the typical difference between 5- and 6-year training programs? Because these both do exist out there.
Yeah, I would say the 6-year programs are fewer and far between, more shifting towards 5-year programs. And generally the main difference is just the research component. Most of the 6-year programs have some kind of, whether it's 6 months or 1 year, but some kind of dedicated research time. And certainly for most programs, I don't think that historically the 5 or 6-year training makes any sort of significant difference in perception from other places when you go on to fellowship or working afterwards.
Very good. What about you, Gina? What would you say?
Yeah, just be aware some differences in 5- and 6-year programs involve different, also not only the research component, but they may require you to spend more time in general surgical training. So there may be more time within general surgery during the early years, internship years, and the longer training programs. But the outcomes between 5- and 6-year training programs in terms of resident job placement and clinical training I think in most, they're viewed as equal. It has to do with, what your priorities are, what your timetable is like in your life, and even thinking ahead, what your plans potentially for fellowship are. Thinking of some of the longer fellowships, such as pediatric urology, which range between 2 to 3 years. You might want to factor that in if you're anticipating spending 2 to 3 years in fellowship after completing residency. That might factor into what structure and length of training you want for your residency.
Excellent. Okay, let's keep moving. Next slide. Okay, back to Dr. Badalato. So what avenues exist for a student to increase his or her fund of knowledge now? Let's say I want to get smart. I want to be ready for my sub-Is. What can I do?
So definitely this is a great opportunity to make everyone aware of the AUA core curriculum, which is available within the AUA website. We have different modules that go through the how to perform a focused GU history and physical exam, and different subject headings that review core areas in urology, such as the evaluation of prostate cancer, the evaluation of a pediatric patient, the metabolic evaluation of stone disease. This is a great opportunity to get some condensed information to prepare for your sub-Is. Aside from that information, students that I've worked with have found Leader's Guide to Pocket Urology as a good kind of quick reference to boost their fund of knowledge and facts about urology. And then when they're scrubbing into cases, a lot of the students that I've spoken with definitely review their Netter's Atlas of Anatomy, and have also looked at Hinman's Atlas of Surgery, just so that they're familiar with the steps of the operation and the anatomical detail of what's going on.
Okay, great. Dr. Kreshover, what would you add?
I will also, just like Gina, make the plug for our wonderful medical student curriculum on the AUA website. The couple of extra things that I think are valuable are just the videos are very helpful, and I think especially things like male and female catheterization, where you may not get as much kind of direct teaching on that in medical school. The videos are great that way. The only other thing I was going to say, and potentially as a student, but also further on in training, as technologies have changed, even things like YouTube, watching videos and seeing the quicker explanations of steps is sometimes valuable. But always, as Gina was saying, the preparation, anything, the fund of knowledge is mostly about preparation and preparing before cases, doing your best to prepare each day for the patients that you're rounding on, et cetera, is really going to help you in increasing your fund of knowledge.
These are fantastic answers. I would add, know your patient. Know your patient, know your patient, because that is really the key to all the knowledge you're going to need to impress the people on the wards. But I think it's worth repeating a couple of the resources you just heard from Dr. Badalato and Dr. Kreshover, and that's the Pocket Guide to Urology, which is, I believe, the author is Wiederman, and then Hinman's Urological Atlas, which really is a urology-based surgical atlas. Those are two good resources. And then, of course, can we go to the next slide, please? Of course, we have to talk about the knowledge that exists through the AUA membership. If you join the AUA, you have access to fantastic resources, and that is the core curriculum, which is really maybe above the medical student, I would say, mindset. We're going to come back. Let's go back one slide, please. I'm talking a little bit ahead of what we're talking about. The AUA core curriculum is really for residents and urologists, but actually has fabulous information for medical students as well. Specifically for medical students, there's actually a specific curriculum just for medical students on the American Urological Association website that is written only for you. And we'll get to a slide of that and explain that. But this exists for you, and I would encourage you to join the AUA and get access to this. So let's go back to Dr. Kreshover. Should a medical student consider going to the AUA national meeting? And this year it's in Boston. What do you think, Jessica?
Absolutely. I think that it's kind of awe-inspiring to see for the very first time just the breadth of urology. It is by far the biggest meeting. It's called a national meeting, but it's certainly very much international. It's bigger than any of the other international meetings, both urologists in and out of the United States. And I think that it gives anyone a big sense of kind of, again, the stuff going back to the beginning with the diversity of urology, how things are changing in the field, and kind of even, one of the things I think that attracts people to urology is they say, you choose a specialty based on the personalities. And I do think that there's something to be said about that. And certainly at a national meeting, it's great to get to see the people and the camaraderie, et cetera. It's a fun and educational time.
Excellent. And what would you add to that, Dr. Badalato?
I completely agree. It's a great opportunity if you have the chance to go, especially, again, with the focused AUA initiatives towards medical students. We are compiling a list of valuable meetings, either society meetings, such as partaking in the annual meeting that the urology residents have at the AUA, or different workshops or presentations that are particularly valuable for medical students. That list is something that we're putting together as part of something that's available for medical students through the AUA, which workshops and meetings are most valuable for the student. But if you can't attend the AUA, that's okay too. We all understand that there's limitations to people's resources and financial limitations, but you can definitely follow along on Twitter or online the different presentations that are being given at the AUA, and in that way partake in the experience.
Yeah, this is a great time to go to the next slide. Why don't we transition over to that? So yes, the miracle of Twitter will give you the opportunity to virtually attend the meeting. And I tell you what, I challenge you to find a specialty that is more Twitter friendly than urology. Urologists love Twitter. It's just like a match made in heaven. So I would say there is a huge amount of urology leadership on Twitter. And a good place to start is with the American Urological Association's Twitter feed. But at the meeting, we're going to have handles that people are going to be tweeting out specifically with medical students in mind. And this is hashtag MedStudent, hashtag Urology Match, AUA 17. These are all things that you can follow, the feeds from the meeting that will give you highlights about things that are probably interesting to you. I would encourage you to follow along. As Gina was saying, even if you can't make the trip, that's okay. Be a part of it virtually. Be a part of the community and see what's out there. I think you're going to be very impressed with how with even the conversations that go on between urologists on Twitter. Okay, next slide, please. Okay, so Dr. Badalato, how does a medical student get involved with the AUA?
So a medical student can join the AUA. The membership is free, and it's a great opportunity, again, just to get linked in with the community and be aware of what's going on in the field. I will say that if you registered for the match and recently matched in urology, or just registered for the match, that registration process doesn't automatically sign you up for the AUA. That just gets you an AUA ID. So even if you already matched in urology and you're looking towards finishing the second half of your year in medical school, this is still something that's applicable to you. So I would definitely encourage students to join the AUA, this level.
Okay, excellent answer. What do you think, Jessica? What would you add to that?
I basically just say the same thing. I mean, I think there are various ways to get involved, but at a minimum, just signing up to have access to the resources, I think, is really going to be helpful.
Yeah, I completely agree. This is such a valuable resource for a medical student to join the AUA, and I didn't know about this when I was in your shoes. Can we go to the next slide, please? This right here is just a quick snapshot of the page you go to join and apply for membership. It's kind of cut off there a little bit at the bottom, but membership is free for medical students. There's really not a reason not to join because the reality is you're going to get access to not only the AUA National Medical Student Curriculum, you're also going to get access, I believe, to the core curriculum, which is fantastic. It's a great community to be a part of and to start now if you're interested. Okay, next slide. Okay. We've touched on this a lot, but it's important to touch on because this is stuff being designed specifically for you. So, Dr. Kreshover, what AUA resources exist for use by medical students?
Yeah, so the ones that we personally are most involved with, again, are the AUA Medical Student Core curriculum with the both problem-based cases that go through the major topics in urology, as well as the training videos, et cetera.
Okay, great. What do you think,
Yeah,
Dr. Badalato?
yeah, agree with that. And also, there are summer grants and scholarships that are available to students. And depending on the amount of time that you have dedicated towards research, you should definitely check out within the medical student um, webpage within the AUA. There are a list of different resources, scholarships, and grants that can be awarded based on what time and resources you have to conduct clinical or basic science research.
Excellent. Very good. Why don't we keep moving to the next slide? This is once again just a brief snapshot of what you go to when you actually access the education for medical students under the AUA webpage. You'll see up in the top right corner there's a video that a really well done video about how to do the male genital urinary exam. This in my opinion, and I think all of us that have been on this committee, this is one of the best resources if you're trying to learn how to do an appropriate genital urinary exam. Hard to imagine where you would get this knowledge in any way, better shape, or form. In addition, there's different case presentations, and on the bottom right-hand corner, you're going to lose some of that down there, but we go through pediatric UTI, adult UTI, kidney stones, incontinence, hematuria. These are all workups with questions and case presentations specifically for you. There's an app, and I would encourage you to download. Go to your Apple Store or whatever store you're using, download the AUA National Medical Student Curriculum app. Easy resource for you to have on your phone and just play with when you're on a bus or a train and to get knowledge. Okay, next page. This right here is some of what else we were talking about, the Summer Medical Student Fellowship Program. Unfortunately, the deadline for this has just passed, but in the future, if you're looking to spend a summer doing research as a funded medical student through AUA auspices and resources, there is an application program you can go through, and it's competitive, but you apply with mentors, and you'll get a scholarship and funding to do research for a summer for urological research. Okay, next slide, please. Okay, I think it's a very important question because we have two superb examples here, Dr. Badalato and Dr. Kreshover, of women that have succeeded in urology. And I think we all experience this because we all see medical students all the time, and a common question to us is, what about women in urology? How does that work? And I think we got to spend a little bit of time on this. So I want to start with Dr. Badalato. How would you answer this question? What has it been like to be a woman in the field of urology?
I will say that it's becoming less and less a novelty to have a woman to be a woman in urology. Just looking at the match statistics, more and more women are entering the field each year. And as years pass, although there are not that many women comparatively, I guess, compared to other surgical subspecialties and other fields practicing urology, with time there's going to with the number of women in residency, there will be more and more women in practice. In terms of how you're treated, the experience during residency, I would say it's no different in terms of your treatment, your rapport with other residents, and your expectations compared to your male counterparts. For the most part, patients are blind to your gender. They just want good care. They want a doctor that's invested in their care, that's knowledgeable, and that is focused on their specific problem. There are some rare occasions when you will have a patient that has a gender preference, but for the most part, that's part of the course, and I really don't take that personal. That's just that patient's personal preference, and I will say that that's a rare. That's something rare that I encounter now in my practice, if at all. One advantage is that women do like to see other women, and it's been kind of something I didn't anticipate during my residency, that I would have such a practice that was focused on treating other urological problems for women, but is really developed into a great niche that I have within my practice now, particularly within the field of voiding dysfunction. So overall, it's been a great experience to be a woman in urology, and it's an exciting time when more and more women are entering the field.
Excellent. Very good. Jessica, you have an interesting background because you come also from an engineering background, which also tends to be perhaps a little more less prevalent on female participation. And then you go into urology, which once again, it tends to perhaps have less of a prevalence of women. What has been your experience along the way?
Yes, so that is absolutely true. I've always been, in a way, I guess, the minority in both of the fields. I think kind of just what Gina had said. I think male patients actually tend to have less gender preferences than female patients do, and being that a practicing female urologist is just a lot less common, although it's becoming more common, it's a lot less common than a male. It's been extremely unique to see just how far people go to seek out a urologist who happens to be a female in practice. And so I think in that way it's been, like Gina said, a blessing in terms of growing my patient base and things like that. The other part is that from a colleague perspective, I mean, I was the first female hired in my department, had, I think at the time, like 18 male partners who I think potentially view me a little bit different than everyone else, but in a good way, you know, look out for me, very much so. And I think that in terms of colleagues, it is such a novelty that I have many gynecologists and primary care, et cetera, that really seek out in terms of their patients and trying to get patients to see me, just because there are people that do have some gender preferences. I certainly in training was, like Gina had said, was not expecting necessarily to have quite as much of the patients I see be female, but it's probably like a 50-50 split, which is higher than most of my male partners, but still for me has been wonderful.
Yeah, and I want to just echo. I think there's such a welcoming, open arms to women that want to go into urology. There's the Society of Women in Urology. There's specialty interest groups. This is something we want to see increase because they're fantastic. We want the best people to go into urology, no matter if it's a man or a woman. I'm obviously a man that went into female urology, and I see it's kind of weird because I went into probably a male-based specialty, and then I started specializing in female urology, and I see predominantly women patients. But I tell you what, people are blind to expertise and to professionalism. And no matter what you do, if you go into urology, we want the best, and we want you to be professional and good at what you do, and you're going to succeed. Next slide, please. Okay, great. So now we want to go to some questions from our audience. And let me see here. I'm going to expand my docket here to look at some questions because this is a very important part of all this. Let me see through here. Oh, these are some in-depth questions. Okay. Okay, let me see here. So let's go back. So Derek Sheen has a question for us. Do most urologists work in private practice or hospital affiliation sites? I think it's a good question to answer for people. Dr. Badalato, what do you make of that? Do most urologists work in private practice or hospital affiliation sites?
I think it's a mix depending on, where your geographic area of interest lies. Within, New York, I would say more people may be a little bit more private practice focused, but it definitely varies, in your geographic area of focus. I don't know. What do you think, Jessica?
Yeah, I think that there's a shift more and more towards hospital-based, at least in some sense. A lot of times people have, I think, a mix of basically hospital and private practice-based. Um, it's more prevalent to shift towards the hospital-based in primary care as healthcare has changed. In that it's just hard for a primary care physician to sustain a private practice. And I think that honestly, with time, probably there will become more of that shift in the subspecialties as well. I agree, though, with Gina. I think more now is private practice based, but I suspect that is changing and will continue to change.
I think those are good answers. Okay, we have an anonymous question that I want to put out there to our panelists. So if you had an experience as a personal experience in childhood or adolescence with urology, What do you think about bringing that up in your interviews or in your personal statement? What would you say about that, Jessica?
So I think it's pretty common in the personal statement to try, and there are many people that in their personal statement bring up. I mean, I can think that there's at least several every year with a family member with prostate cancer or testicular cancer, or how that kind of shaped them, or personal effects like that. I think there's no issue in that whatsoever. I mean, everyone has a different reason for kind of why that initially sparked their interest. I would think with anyone, I mean, much more about your application is not really just the one reason for how you became interested, but what you've done all around. So it's not something that I think that you have to worry about it defining you, but there's nothing wrong with discussing it.
Sure. And what would you add to that, Gina?
Yeah, usually the essay, as Jessica mentioned, is the avenue where people kind of open up with a personal vignette or experience about what led them into the field of urology, and then go on to talk about, what developed that interest. I agree. It's common to talk about an experience with a family member or a patient that you saw in the wards and how that piqued your interest in urology. I would be a little bit wary about opening up about if your own personal experience, in that if you had a urological issue, a problem, or surgery, and putting that in the essay, um, just because that uh, you may end up discussing that on every interview, and you just have to be comfortable with that degree of sharing of your personal life. I don't think that will affect in any way how people view your application and your eligibility or fitness to be a resident. But it is, when you're talking about yourself, um, that is, a different level of personal. And, you know, um, I haven't seen too many essays that would open up on that level. Much of it is about, again, about a family member or a patient, but not as much about themselves. So if it is a self-focused, I would talk it over with a mentor who can review your essay and give it a little bit more personalized attention to see, how that would be received.
These are great answers. I want to keep moving because we actually have a lot of questions. Okay, this question's coming from Timothy. How do we find out which programs are within our reach based on our application? Okay, I'm going to add my little bit about this. I think it's really based on your mentorship there within your institution. Hopefully you have someone you can talk to. Urology, whether it's urology residents are usually good resources for this because they've just gone through the application process and they can give you their insight based on your numbers where you might be appropriate to go. Or perhaps, a urologist, an attending that you feel comfortable with that's serving in a mentorship role for you. What about you, Gina? Would you answer that in any different way?
I agree. Just also, it's good to touch base with your dean of students because they have records of the students that have matched the years before you and what their USMLE scores and what their credentials are, so you can see what institutions have taken students from your school and how you match up.
Great. What about you, Jessica? Would you add anything to that?
I would totally agree, and then just say that in students that have matched before you, kind of the same thing as you were saying, but to reach out to them. People in residency or just recently out of residency are going to have much better perspective as to the smaller stuff and the ways that, because programs definitely change over time, and there are small things. Urology is not the same. No residency program is the same as the university or hospital that it's affiliated with. And so you don't want to basically bunch them together and say because XYZ school is this way, therefore its residency program is this way.
Okay, great, very good. I want to keep moving. So we've got a very pertinent question from Jacqueline, who asks, is it kosher to ask an institution that only offers 4-week sub-internships to allow you to complete only a 2-week sub-internship? So you're going to ask to just do 2 weeks instead. Jessica, what do you think about that? Can I only do 2 weeks if they're offering me a 4-week sub?
I've had multiple people ask that. I do that for our department. I think that it's fine enough to ask with the understanding that for a lot of programs that may not logistically be possible, Obviously, everyone wants to do their best to accommodate. I think you do put yourself at a little bit of a disservice that way, just because it won't be structured in the same way as a full sub-internship is, and that's kind of what obviously they're all used. That's how we base the rotation. But I think there's certainly no detriment in asking.
Okay, very good, very good, excellent. I want to keep moving here. Jody, are you there? Can you hear me? I got a question that we're going to need your input on, I think.
Yes, I'm here.
Okay, so we have a student that put in his application to join the AUA, and he was told that it was going to be reviewed by a committee, and he hasn't heard back in a couple of months. Is there feedback about that process when they hear back about membership for medical students?
I would definitely email membership again. Their email address should be on the website. For this particular person, I can reach out to you directly and pass along your contact information to our membership department. But I would definitely follow up with them and make sure that it just didn't get, somehow overlooked.
Right. So, okay. So to the person that asked that question, maybe if you send your email in to us or some, I think we probably have your email. We'll try to identify you afterwards and get back to you. Okay.
Yep, I have the email.
Okay, perfect. All right, excellent. So let's go back to our excellent question base here. So someone wants someone wants to know. This is more of a pelvic floor question. So this is, I'm sorry if I'm saying your name wrong. Neobra wants to know and we'll direct this at Gina for right now. When working with the female patient population, what are some of the differences between the expertise of procedures performed by a urologist versus a urogynecologist, as they're pondering going into either urology pelvic floor reconstruction or urogynecology, perhaps.
Okay, so the differences are the training. Obviously, if you're pursuing, you're going to basically have a residency training gynecology versus urology. Urologists are trained in different reconstructive techniques that I don't think are covered in many of the gynecological fellowships. These come into play when you're repairing fistulas, have different questions or issues with potentially the ureters, the upper urinary tract. I would say that those are many of the differences. Seth, you could probably elucidate on this further.
Yeah, all I would say is this: in the world we live in today, there's the specialty of female pelvic medicine reconstructive surgery. Essentially, if you're a urogynecologist or urologist that's done a specialty training, you should have an equal skill set. Now, that doesn't always work out, and that doesn't work out based on your training and your fellowship. But hypothetically, when you finish your residency and your fellowship, those two populations of surgeons should have an equivalent surgical skill set. Inevitably, the gynecologists probably have a little more experience with vaginal reconstruction. Urologists have more experience with robotic and abdominal reconstruction. But hopefully, the training is robust enough that when you finish, you can manage pelvic floor reconstruction well. Now, inevitably, the nice thing also about that specialty is there's a lot of combinational work that goes on between urogynecologists and female urologists, and it makes for a fun working environment. I want to keep moving really quickly because then we're going to direct this question towards Jessica. So Jessica from Evan, he's asking, what should first or second year medical students be doing if they know urology is their choice for residency?
The best is to get involved as early as possible. So that, and to kick some butt on the USMLE. I mean, really take the USMLE very seriously. But the earlier urology is small, the earlier the department knows you, the longer opportunity they have to get to know you well, and to help you at every small step along the way. One of the things I don't think that we talked about before, but in part of the application, there's always the part about research, and people ask questions about research. I think all of us agree. I mean, the biggest thing is getting research in and getting publications. Publications are viewed very positively in an application, and it does not have to be within urology. And so obviously it's better if it is, but it absolutely doesn't have to be, just to show that you're dedicated to it and getting something done. And so by getting involved in your first and second year, that gives you far more opportunity to get involved in small ways and get your name on things to build your application for later.
Okay, that's a great answer. I want to keep moving because we have a lot of questions. We have a question from someone that's had a personal history of germ cell malignancy. and he's asking, how many hours would you suggest before, shadowing urologists before you really believe it's the right specialty for you? I mean, how much convincing of yourself should you be doing that urology is the right field for you? When was that magic moment for you, Gina? When did that happen?
This is not like a training log where you have to put in a discrete number of hours before you reach the threshold where you can declare it as, the field for you. For many people that come into urology, just say they, on day one, they just knew it was for them. It's a combination of just feeling that you have a good grasp of the personality, the field, the skill set of the urologist, and the problems that they encounter, and it's more importantly your degree of comfort with and security and just confidence in the path that you're forging ahead. So if you're on the fence about pursuing another field, I would, do sub-Is in both fields, and then students are usually able to reconcile their experiences between both fields and then declare which one they like, which one they like more. I will say, because urology is an early match, I always encourage people to explore urology earlier so that they can at least have that experience and potentially get the wheels turning for their application, because it's easier just to cancel their application rather than start to build one at a late time.
Great answer. Okay, we're gonna move on to the next question. This is for Jessica. So Jessica, Alexander is asking, as a DO candidate, what are your recommendations for applying? Can you give him any guidance?
The best is to reach out to programs individually during the application process, because it can be one of those things, kind of like a USMLE, where people may place certain filters to look at MD candidates versus DO candidates. And I do, for better, for worse, I think that the tendency is that as a DO candidate, you kind of have to do that much more over a traditional medical school candidate, MD candidate, to kind of make your application stand out.
Yeah, I think I want to. What about you, Gina? Do you have anything to add to this? Because it's definitely a unique question.
There are some programs that exclusively, they're DO training programs in urology, so I would definitely focus my attention on those programs. But I do, agree with Jessica that the climb is a little bit steeper coming from a DO as compared to an MD program. So you want to have realistic expectations based on your grades and your score, about what would be a good match for you, and then definitely do a sub-internship at that one of those places and really showcase everything that you have to offer, so that when they meet you and evaluate you during the sub-I, they truly get a sense of who you are.
Very good. I want to move on to the next question. So this comes from Andrew, and we'll direct this towards Gina to start. So he thanks us for spending our time. You're welcome. We enjoy this. We're passionate about urology. His question is there a special consideration that he should take into account when applying to programs if he's more interested in entering an academic setting than a community practice setting? Should he be looking at special programs? What do you think, Gina?
People that are more interested in academics tend to gravitate towards programs that have some component of research time. It doesn't need to be a dedicated year off and a 6-year program, but some component of the residency dedicated towards laboratory or clinical research, so that you can get a feel for that and start boosting your resume. And so you want to think about that, and you want to look at the track record of the people that have graduated from the programs and where they have headed. Was it exclusively to private practice? Are they putting people through fellowship? Are these people then going on to academics? So you want to just pay attention to the kind of the tradition and the legacy of that institution as well.
Very good, very good. I'm gonna move on to another question here, because we're trying to answer all these, a lot of them. So this is from Stephen, and this is for Jessica. Jessica, is there a consensus recommendation regarding taking or submitting Step 2 CK scores to programs? What do you think of that?
There is definitely not a consensus about it. I pseudo-subscribe to the adage that if you have not had as strong of a Step 1 score, if it's borderline or on the lower side, and you can do very well on the step 2, then I would take it and do better on it as a way of, again, displaying. I mean, the biggest concern with a lower USMLE score on step 1 is, are you going to be able to pass the boards? That's a big way that residency programs are judged. And so one of the predictors of that is how well you've done on the standardized testing before that. And if it's a little bit weaker, then doing better on the second. The converse, though, is also true. If you've done well on 1 and you blow off 2, people very well may notice when they actually sift through the applications.
Okay, very good. So Jessica, I want to come back to you with another question. So what are the differences, and I think this is a very important question, I'm sorry I didn't answer this earlier, what are the differences between nephrologists and urologists in the kind of conditions they treat and what procedures they perform?
So a nephrologist is a medicine doctor for in very general senses, whereas a urologist is surgical. So the medical issues, I mean, a nephrologist doesn't really perform any procedure. They may perform some kidney biopsies, but I think even those most of the time are done, at least at our institution, are done by interventional radiologists and not nephrologists themselves. And most of the time, you're talking about with a nephrologist, our disease is intrinsic to the kidney. So nephropathies, things like even how diabetes affects your kidney function, etc. Whereas a urologist, it's things that are surgical, so tumors, stones, etc. when it comes to the kidneys.
Let's do this. Can we go to the next slide, please? I want to do the thank you slide, but then we're going to keep answering questions for another few minutes here. So let's, so Jody, we'll go to the, so a quick thank you to, because I know it's 6 and people are 9, people may start closing out. I want to thank Dr. Badalato and Dr. Kreshover for being wonderful panelists and really giving superb input to our attendees tonight. I want to thank the AUA webinar team, Patrick Curley, and Jody, of course, Jody Donaldson, for her fantastic help with this. And then we want to give a very large thank you to Dr. William Hulbert, who's the chair of the National Medical Student Curriculum Committee, which is a curriculum committee that's specifically dedicated to medical students run through the AUA. And of course, to our fellow curriculum committee members for giving us the opportunity to do this. We're going to keep going here and answering some questions, so feel free to stay on.
Thank you to you, Seth.
Sure.
It's an amazing voice.
My pleasure, my pleasure. Okay, so this is a question from Sunny. Sunny wants us to know, can we briefly, and let's direct this towards Gina. Gina, he wants to know, could you briefly mention some of the most common conditions and procedures done by a general urologist,
Okay, so common conditions, general urologists may deal with kidney stones and procedures related to taking care of that, like shockwave lithotripsy or other forms of stone removal. Voiding dysfunction, that can be in men, BPH, or in a large prostate where they have obstructive symptoms, like frequency, getting up a lot at night to urinate, urgency, since that they're not emptying their bladder fully. Urologists can introduce different forms of medication for that and do some procedures to help them urinate better, more common being something called a TURP, or a transurethral resection of the prostate. Urologists in the community may deal with things like recurrent urinary tract infections, working up a patient that has blood in their urine, dealing with an infertility consultation for male factor infertility, or performing a vasectomy in a man that may no longer want to have children. Those are working up an elevated PSA, or an elevated prostate-specific antigen test in a man, and doing a digital rectal exam, potentially leading to a prostate biopsy. These are all very common conditions that urologists in the community may encounter.
And you can see just from that list, my gosh, how broad, right? That's why it's a fun specialty. There's so much to do. Okay, let's keep moving. This is for Jessica. So Jessica, Andrew thanks us for this talk, and he wants to know if we've noticed, or anyone's noticed, a difference in regionality as far as the type of urology you practice, in urban versus rural versus west versus east coast. Do you think there's a difference in the way urology is practiced?
I think the biggest difference is in urban versus rural. In more rural areas, there's far less urology representation, and as a result of that, there is far more diversity to what your patient is, what the diseases are, and what, frankly, as a urologist, you are in a way expected to do. I think that it ends up being more common to do both pediatric and adult urology, whereas in the big metropolitan areas, that is few and far between are people who treat both adults and pediatrics. And then really, you know, Gina just went over like the common things that urologists would do, and implied in that is that some of the bigger things, like bigger cancer surgeries and stuff, would be referred to more tertiary care. And I think that, again, in a more rural setting, that's where the urologist takes on a more active role in kind of those bigger procedures that would maybe referred in more metropolitan areas.
Excellent. Okay, Gina, this question's for you. This comes from Anthony. What suggestions do you have for students from universities without home urology residency programs?
I would suggest that you find a mentor, either in the form of a nearby affiliated urology practice, reaching out to the general surgery department within your institution and seeing if they work with any urologists for any of the cases, or as a referral base, and starting from there. You may want to find out graduates from your medical school that have gone into urology and reach out to those people as a networking avenue so that they can help you navigate a path towards applying in urology and support your application.
Very good. Very good. Anything to add to that, Jessica?
I think those are all good suggestions. It does tend to be a little bit harder, and I think we've spent a lot of time focusing on mentorship. And kind of to touch on that, I think that it does not necessarily have to be that it's someone from your own institution that can provide that mentorship role. I think honestly, I think I speak for all three of us, that if someone had a random question or felt like they wanted to know something, you know, some other resources, I think any of the three of us would be happy to answer, or at least attempt to try and point you in a better direction.
And that's exactly right. And I think that's another reason for you to join the AUA as a medical student member, because it gives you access. You have a group of people at the AUA that are connected to us, and urologists out there that are excited to be mentors and really participate in your education. So I would encourage that as an avenue for sure. Okay, this question comes from Luis, and Luis is asking, and we'll direct this towards Jessica. I don't know if we can answer this, Luis, but it says, how can the repeal of the ACA impact the urology field? Can you answer that succinctly, Jessica?
Yeah. I mean, it's definitely a harder question for me to answer not being in private practice. I think that is a far more important question for someone that's in private practice than someone who's in academics. I mean, yeah. For me, it's about it's whatever patient comes through the door.
Yeah, and I think Luis, whatever happens, you know, urology is going to be okay. It's a good field. It's well reimbursed. You know, urologists are generally happy with you know. There's never a perfect situation, but they're generally very happy. Okay, this is from Tyler for Gina. What are some good ways to stand out as a medical student on a urology sub-I?
Good ways to standardize. I'm sorry.
Just stand out. To stand out and be a star.
Okay.
Yep.
So basically what you already mentioned, know your patient, be prepared, basically review the OR schedule in advance, look up the patient, make sure you're clear on the indications, why they're having the procedure, you're familiar with the anatomy and the field that's going to be involved in the surgery, taking initiative on the floor. Now, we haven't talked about the role of residents, but the residents are really involved in selecting who they want to kind of come into the fold and join their family, because not only is it a commitment among the faculty, but these are people that are going to be your colleagues for 5 or 6 years during this formative period of your life. So you want to be helpful to the residents. You want the residents to be able to go to bat for you and say, this person really took initiative in seeing patients on the floor. This is someone that we want to have within our group, had a good personality, we had a good working relationship with. And anytime that you're given on your sub-I an opportunity to present to the department, you want to make sure that presentation is really well thought out. It's a good topic that you're comfortable on speaking on. and very well researched. And that's something that you can go over your talk with the residents that you're working with or any mentor that you have to make sure that everything that you're comfortable and the talk is, really reflective of everything that you know.
Great. Okay, we got just about 5 minutes here, so I want to get to a couple more questions. This is for Jessica. Jessica, Lindley is asking if an applicant has not been published yet, is that enough to immediately cut them from your list?
Absolutely not. Yeah, I mean, that's the simple answer, is absolutely not. Research is not at all a prerequisite. It's something that adds to an application, and it's absolutely not necessary.
Got it. Okay, we'll go back to Jessica for this as well. It's a very specific question. For students who are not geographically restricted in their application process, would you recommend applying to away rotations with more well-known names in the field of urology rather than just strategic locations to unlock certain AUA regions? Would you go to the big names in aways?
Number one, congratulations. That's wonderful, and that's a very good outlook. Number two, I don't know. I don't think so. I mean, I think, again, it goes back to programs that you feel like you're in the most interested in, and not necessarily the ones that have the biggest names. I think your sub-I should be about going to places where you want to go, and that is absolutely not for geographic regions. Just like we talked about, if you feel like you're more interested in the academic track, then I would try and go to a place where people go into fellowship and go into academic jobs. If you are really interested in a program, if you feel like you're interested in pediatrics, go to a program that, that rotates at some of the biggest pediatric urology facilities in the country. Those, I think, are the ways to make it, and not necessarily what city you're in.
Great. Okay, this is a good answer. Gina, this is going back to you. What, with urology being, this is from Luis, with urology being so competitive, what can a U.S. international medical student do to increase chances of matching? What do you say for our IMGs, for our international medical students?
Definitely get involved with the department in the form of research, clinical research. It really can, help distinguish your application. Investing time with a mentor so that they can write you it's not even about the publications. It's just getting a mentor within the U.S. that can write you a really strong letter of recommendation and endorse your talents. And then definitely doing sub-Is at realistic places within the United States, doing well also on any standard on all the standardized tests that you're taking. These are all ways to help distinguish yourself, but the biggest thing is getting a good mentor, and research is definitely the avenue to establish that relationship.
Very good. Okay, we got just a couple more minutes here. So quick answer for this, Jessica. So Scott wants to know, what is your opinion with respect to letters of recommendation from chief residents or fellows?
I've never seen one from a chief resident or a fellow. I mean, it would be out of the ordinary to have that. Most, if not all, letters are from faculty.
Yeah, I wouldn't recommend it. I think you got to try to find a faculty member to write your letter of recommendation. Okay, well, we got about another minute or two here, so I want to take this opportunity again. Unfortunately, we're not going to get to all the questions. I apologize about that, but hopefully you gleaned a lot of information from this discussion. I want to thank Jessica again, thank Gina again, thank everybody for participating. We love to interact with you at the AUA meeting through Twitter, whatever way we can do that, and we welcome you to the field of urology. We're excited to have you join us. You're in for a treat. It's a wonderful, wonderful specialty. Thank you, everybody, for this evening, and we wish you a good night.
Thanks, everyone.
Thank you. Good night.
Night.
Good night.